All right, welcome back. My name is Thomas Stott. I'm alongside Dr. Patricia Stott. We are Elevation Wellness. Here today to talk to you about Ehlers-Danlos syndrome, so EDS, but this time taking the angle of craniocervical instability, so CCA, diagnosis and non-surgical management. Now, very important for this one, as it is for all of our lectures in this series, but this presentation is not meant to diagnose or treat you. Please be sure to consult with your physician regarding any treatment or testing. This is for informational purposes only. With that said, let's get started. Now, this is a pretty science-heavy lecture and a lot of material to get through. But our learning objectives, we've pinned them down to 4 things. We need to understand what CCI is and the symptoms it may present with. We need to become familiar with the tests that need to be done to determine if there is an issue. Learning other issues to watch out for that may present with similar symptoms will be our 3rd stepping stone. And our last one, we want to learn non-surgical treatment approaches that may help reduce your symptoms.
CCI, or craniocervical instability, you can also call this occipitocervical instability. This is where the head meets the upper cervical spine. And at this junction, the head sits on top of the cervical spine and usually involves the 2nd and 1st vertebrae when we look at it there. So C0, C1, and C2 is what we refer to the head, to that 2nd vertebrae as. And the ligaments in this area, they help stabilize that head, the big skull, right onto the top of the cervical vertebra. So it's a very precarious setup. Usually works well unless you have some instability going on. And you can have ligaments fail, whether it's over time from micro trauma or from a more significant trauma as well. And you'll end up losing stability, which can cause a lot of problems. You can have, just like any other joint in the body, different types of instability depending on what's affected. You can have horizontal, rotational, and vertical instability going on. So it doesn't just have to be one type of instability that you have. It can be a combination or, just one of those 3 that's going on that are causing issues. When you have instability, it can also cause issues at the upper cervical spinal cord, the brainstem itself, and the cerebellum. And this is where you can get some of those funny symptoms that aren't necessarily orthopedic, more neurological type symptoms, balance and vestibular problems, and things like that with those things involved. And a lot of people complain of this feeling of a bobble head or a really heavy head or the wobble head that can happen because of the instability. We've talked about this topic before in some of our other presentations on hypermobility versus instability. This is a huge thing to consider and things that need to be researched when you're looking at this area of the spine. And just like we've said in other joints, hypermobility does not always mean that the area is unstable. So this is really important to understand, that you really need to have this investigated to see if there is instability versus just hypermobility. Just because you're hypermobile does not imply that you are also unstable. Instability can happen for a number of different reasons in this area, the same as others as well that we've talked about. It can be anatomical, so you can have just a change in your anatomy compared to the typical structure that offers more support. If you have bony defects in there, if you have abnormal shaping of the bones, and if you have some potential loss of bone integrity like osteoporosis, that can change the stability of the any joint really, but even of this area up here by the head and neck. You can have defective or non-functional ligaments, and this can happen through trauma, genetics like a connective tissue disorder, but can also happen over time as well from multiple microtraumas. And then you have this dynamic versus static instability. So, without movement, are you unstable? Is something going on that you're causing compression or a kink in the brainstem just not moving? Or is most of your instability potentially with movement, which they call this dynamic instability? So again, things to be explored by your doctor that's investigating it for you, but there are different ways that you can be unstable, and you can also just be hypermobile as well.
So here's where it starts to get pretty darn tricky if you ask me, as we look at the symptoms associated with CCI. This list looks and reads like what's written on that medication you got from your doctor, that side effect list that's a mile long. Knowing that there are multiple systems at play, this touches on a whole number of things that could also be contributing to these symptoms on this list here. Take brain fog at the very bottom there. If you listen to our GI lecture, you'll know that that could be a basic symptom of some GI disturbances. No GI symptoms present, just seemingly brain fog as what's going on. So a lot of misdiagnosis, and it's because this list is pretty comprehensive. So let's go down it. Up at the top, we have dysautonomia and dysautonomia related symptoms. So this could be due to a change in stress level, an environmental change, but dysautonomic symptoms can mirror those of CCI. Dizziness, vertigo, syncope, fainting, nausea. We have headache, could feel like a pressure, that heavy head Dr. Patty mentioned earlier, pressure or heavy sensation, a headache behind the eyes. We have weakness, numbness, paresthesia or paralysis, impaired coordination, balance problems, gait changes, poor proprioception or body spatial awareness, kind of tying in pretty closely to balance a lot of times. Neck stiffness and pain, pain behind the eyes, pain at the back of the neck, of the head, or the scalp, facial pain. The list goes on, and these are all scientifically reported symptoms, not just anecdotal. Changes in swallowing, shortness of breath, sleep apnea, visual changes, nystagmus, a ringing in the ears, or a change in hearing, especially a sudden change. And as I mentioned before, we have the brain fog coupled with fatigue, general memory problems, or sleeping disturbances. So that's pretty exhausting. I had an audible laugh out loud when I came across this slide that Dr. Patty put together. So we have baby Stewie here for all of you Family Guy friends, demonstrating that his head is too heavy for his frame. Certainly could be suffering from some CCI, and regardless of which type, we have to understand that that's a pretty fair complaint to have. If you think about the role of the ligaments to add support and take a little bit of load off the muscles, those muscles just have to work so hard. So imagine supporting a head on top of your shoulders that can move all of the directions. By the end of the day, or even after a short amount of time, those muscles are going to be pretty tired of working. So, very common complaint, like we said. Enjoy this Stewie picture.
There are three measurements that are commonly looked at for CCI through the tests. The first one is the Harris measurement, and that's a Bayesian axial interval or the Bayesian Dens interval. Anything more than 12 millimeters is considered unstable. You have the Clivo axial angle, the CXA, between the clivus and the axis. Normal is greater than 150 degrees. Abnormal is anything less than 135 degrees. And the Grabb-Oaks measurement, anything over 9 millimeters is considered positive. And we're going to show you those pictures in just a moment. Now, there is another way to kind of confirm the suspicions if it is really coming from that cervical junction and not something else like dysautonomia or some other systemic issue that you're dealing with causing similar issues. And there is a traction device that they can use that's found few and far between in some hospitals that you can go in and have traction applied, and specifically to see if you can relieve the pressure. This is not necessarily something that you can get in a physical therapy office. This is a device actually built to see taking the traction off of the weight of the spine if the symptoms are relieved. Now, there are some doctors that are sending their patients out for, and they can either do it themselves or they send them out to a physical therapist if they're not close by, to have them perform manual traction. But this isn't like an at-home test that you can do. You need somebody that knows what they're doing and can follow the doctor's orders if they're supplied by the doctor as well, to provide a manual traction on the upper cervical spine. And they're looking for relief of the symptoms, and that can indicate a positive test. And you can also, the inverse is also true. By applying pressure through the top of the skull, you'll get an increase in the symptoms that you have as there's more compression in the upper cervical spine. And that's why it's very important to understand that these are not at-home tests to be done. You need a professional to perform these tests, either recommended by your doctor or the doctor themselves. And as for the doctor, it really depends on the doctor that you're seeing as to what tests are going to be done and how they're used to determine your care. It's very different, even when you're looking at the top-notch docs in the US. They actually look at different measurements, and then they also use the clinical presentation of their patient as well. So this is just a whole puzzle that you need to look at and put together, and it's up to your doctor to figure out what your best diagnosis or a combination of diagnoses are. In talking specifically about craniocervical instability and the tests that are done, and we're not talking about Chiari, but the tests that are done for CCI, it depends again on which doctor that you're seeing, but seated MRIs do have a lower resolution. Artifacts are common, and there's no standard for the amount of flexion or extension that they have your head and neck in. So sometimes the doctor will actually order what they call a supine or a lying down MRI. But it depends on the doctor again as to what they request. Now, if you are doing a lying down MRI, they might have you, if you can see the pictures on the right hand side, put you into flexion or extension in that supine position on your back so that they can replicate those angles in that supine position. And it really depends on who's reading your MRI, if they are able to read those angles efficiently, if they are used to seeing those angles, or if you can have those tests that you've had done and take them to a specialist that can read them for you.
So let's move on to a few measurements here. We have the Harris measurement. To take that, if you look down on the picture in the middle, you see the arrows pointing to two lines. That's what we're looking to have represented with the Bayesian axis interval. It's the position of the Bayesian there to that posterior axis line. So that's the BAI. And then we have the Bayesian dens interval, so the BDI. So that's from the Bayesian down to the dens popping up off of C2 there. So this is looking at it from the side profile. More than 12 millimeters in either of those is unstable on an X-ray. The measurements may vary in flexion and extension on X-ray if there's instability, so it's a bit positionally dependent, as Dr. Patty mentioned, under MRI as well. This would be representative of horizontal instability. Dr. Patty will speak a little bit later about how many positive tests that you have. I know more than 12 millimeters here is representative of instability, but they just keep compiling on top of each other. All right, here we have another shot of the Harris measurement, though this time on an image. Up at the top, we have the Bayesian axial interval, and this BAI is normally less than 12 millimeters, meaning that values greater than 12 millimeters could suggest an atlanto-occipital dislocation, an AOD, in a ligamentous injury. What we need to be reminding ourselves, though, especially given the population that many of you zebras, all of us are, is that if this is from an acute injury, a car accident, something like this might play a bigger role. There are people walking around with chronic instability that are going to pop with values greater than 12 millimeters, but not suggesting a dislocation has occurred. Okay, so we need to keep that in mind as we look at our images and review them with our doctors, physicians, PTs, chiros. So let's move on to the Clivo axial angle. And in many regards, this reminds me of the quad tendon that shifts down into the patellar tendon, so creating shear force. Normally up at the top there, we want an angle of about 150 degrees. Down in the middle, we see a little bit of abnormality, some pathological, when we start to get an angle less than 135. So we get some pinching. We start to break down further there, and we start to see a cause of a bit of a kink and some stress deformity in the brainstem. It stretches out over the tip of the odontoid like a fulcrum, and that's what I always think when I see this picture of that kneecap, which is present to reduce that shear stress and force, and there's just not one present here. So that brainstem ends up being that point there that bears all the load. This would be representative of a horizontal instability. Once again, same angle, the clivo-axial angle here. Once again, on an image though, a little bit easier to see, a nice open, well-spaced, 151.1 degree angle there. So brainstem, plenty of room to breathe. You imagine that angle shrinking down towards the 120s and how much pressure it would end up facing otherwise. So here we have the Grabb Oaks measurement, and something greater than 9 millimeters, this would be representative of a vertical instability. So let's look at it. It's going to look very similar to the last couple slides you saw when talking about the brainstem. We have a little bit more of a mass effect, though, as the tip of the odontoid and surrounding ligamentous complex on the adjacent brainstem. Now, to grab this measurement, it's not just one angle. We need to find a line from the Bayesian to C2 first, and then draw a perpendicular line to the dura, and that's your measurement right there. So imagine something at 150 degrees, a far less shallow depth in terms of a measurement down there versus that very sharp angle where it will certainly be more pronounced. The inner math nerd in me is just flipping right now as we see the Grabb Oaks measurement on an image here. So we dropped on the left on that triangle, that long line in the hypotenuse there, goes down from the Bayesian to C2, and then we run those 90-degree angles on either side as we push that line to the dura. And here we have a measurement of 9.8 millimeters. Once again, over 9 millimeters being indicative of CCI.
And what constitutes a positive diagnosis overall? And this is clinician dependent, and there's really more that goes into it than just those tests that we had talked about. So if you have all of these tests done and you only have one positive test on the imaging, do you still have that diagnosis of CCI? And this depends on your doctor. So really trying to figure out your best diagnosis by putting the pieces of the puzzle together. Again, those tests are just one piece of the puzzle. What are your symptoms? Have you had these other pathologies ruled out? And this is why we talked about that traction test as well, to potentially confirm that diagnosis that it is something higher up in the cervical spine and not just something like dysautonomia. And we'll talk about some other things coming up here that might have the same sort of symptoms that are some other pathologies to get ruled out. And then the other big question, which has been brought up before in some of the other pathologies that you need to get ruled out, is have you had CCI symptoms your whole life? Or was this just something that started, and why is it starting all of a sudden? So if you've had this ligamentous laxity in this area your whole life and you haven't had a recent trauma, why are your symptoms popping up now? Is it something that you need to figure out and manage, whether you need to have surgery done or not, depending on the level of instability? If you don't figure out what potentially has flared up your symptoms, even if you were to have surgery done, you may have maybe not the best results afterwards. And we'll go through, as we talk about some of the rehab strategies that you can do afterwards as well, as to why this might pop up, especially if it's something work related, posture related. If you go and have the surgery done and you're not addressing the other problems, and you might have a little bit more difficult of a recovery afterwards. So figuring out where this flare up has come from, is it just that your ligaments have finally just said no more? Has there been a trauma, micro traumas? What is it that is causing the issues in the moment if you have potentially had this laxity your whole life? It's very important to figure out. There are so many other diagnoses that can share similar symptoms that you need to watch out for. And this is not meant to scare anybody with the giant list, but just understand that there are other things that you can look into so that you're potentially avoiding a major surgery if you find out that it's something like a CSF leak that might just need some patching work. So it's important to make sure that you've gone through all of these others, to make sure that you've tried the more minimalist approach to treatment if something else is going on before you look at this bigger approach that's really going to impact your life. And dysautonomia can be another diagnosis that's occurring mimicking symptoms, or dysautonomia can also occur because of CCI. And this is because that vagus nerve exits out in that area with the cranial nerves up in that upper cervical spine. So you can actually have dysautonomia that is caused by this upper cervical problem. And then you can also have dysautonomia symptoms that mimic this craniocervical instability. So it's important to understand that no matter what, if you're showing signs for dysautonomia, that you work on that to see if you can't calm that down as well. But there are similar things that pop up, which we'll talk about. The cerebrospinal fluid leak can happen as well, and that's really just starting to kind of take off an investigation in those with EDS. Low intracranial pressure, high intracranial pressure, which can also be a pseudotumor cerebri, carotid dissection, a vertebral artery dissection, cervicogenic headaches, occipital neuralgia, the patent foramen ovale, which is actually from the heart but can cause migraines, TMJ dysfunction, and mast cell activation disorder. So all of these share symptoms that might overlap and be similar. So just things to make sure that if it does seem like it's potentially it might be TMJ dysfunction, that you're also getting that checked out as well. And those can be happening together, absolutely, as can any other things be happening at the same time that you have this craniocervical instability. But just things to check into to make sure that you're checking all your boxes, and no matter what you have to do for treatment, that you're really getting the best recovery afterwards.
So the next few slides are going to cover CSF leaks. And the reason is that symptoms can be so very similar, and very important to have this ruled out to avoid more complicated procedures. So CSF leaks can be more common in those with EDS, secondary to impaired dura integrity. Remember that connective tissue doesn't just stop in these big orthopedic joints, it's all over. These can be spontaneous, iatrogenic after a medical procedure, something like an epidural injection, or traumatic after an accident or whiplash. And this can mimic POTS and dysautonomic symptoms, CCI, and Chiari malformation as well. So let's open up this a bit more. So let's look down this list of CSF leak symptoms, and you'll see why it could be very similar to CCI symptoms. You're going to find a lot of the same things. We have positional headaches, pain between the shoulder blades, impaired balance, that proprioception coming into play a little bit, photophobia, a fear of light, cognition changes, could be that brain fog, changes in hearing, whether it's muffled, we have tinnitus, popping, cracking, neck pain or stiffness, we have dizziness, phonophobia, which is pretty sure what we think our beagle has when it thunderstorms, a fear of sound, and then arm pain, numbness, nausea, or vomiting. So more on CSF leaks symptoms-wise. Let's go over some less common ones. We have visual changes, papilledema, which is increased swelling pressure intracranially on the optic disc. We have diplopia, which is double vision, facial numbness, paralysis, changes in taste, fatigue, pain, numbness below the arm, galactorrhea or lactorrhea, which is spontaneous breast milk production unrelated to children, tachycardia, cranial leaks, drainage from the ears and the nose, and then some rare complications. Here's where it gets pretty serious too. With quadriplegia, we have dementia, Parkinsonism, or other movement disorders, ataxia, tremors, dysautonomia, syrinx, cerebral vasoconstriction, stroke, stupor, coma, all the way to death. So, gets a bit scary, but buckle up.
Some workup that's done for CSF leaks are brain imaging, spinal imaging, and lumbar punctures. So with brain imaging, an MRI with and without contrast, and about 80% are picked up this way, but it's important that it's actually read by a radiologist that's looking for it and understands how to read for CSF leaks. It's important to know that you'll see this increased dural enhancement, as they call it, which we'll go over on the next slide. But as symptoms are longer lasting and it's been going on for a longer period of time, you actually might have less of that show up in the MRI. But you can show a flattened brainstem. These lateral ventricles in the brain usually have an angle of less than 120 degrees if you are having issues with a leak. The cerebellar tonsillar descent can be mistaken as Chiari as well. And this could be a potential reason for a surgery not to turn out as well, is if there's more of a descent from the cerebral spinal fluid issue than as from Chiari itself. So spinal imaging, MRI and CT myelograms, only about 50% have findings on this spinal imaging. MRIs with intrathecal contrast, with adjusted weighting, just the type of test that would be ordered. And then the intrathecal gadolinium, enhanced spinal MRI, and then CT myelography are all ways that you can pick up potentially the CSF leak. Lumbar puncture, measuring the pressure to see what the pressures are in the spine as well, that's another way that they can measure to see if there's anything going on with the cerebrospinal fluid. There is an acronym called SEEPS, which represents the 5 common findings that are found in about 80% of people that do have CSF leaks. And they find this subdural fluid collection, an enhancement of the pachymeninges, engorgement of venous structures, pituitary hyperemia, and sagging of the brain. So we're not going to get into the specifics of all of this. That's for another time. But it's just important to note that would be what you're looking for to have read on your imaging to see if potentially CSF leak is something that's going on. But on the picture that's shown there, that's where you find that enhancement of the pachymeninges. So you have a little bit more of that white shading that's around the brain in the MRI images.
All right, so CSF treatment. From the conservative standpoint, bed rest, just resting, staying well hydrated, drinking plenty of fluids. From a vascularity, like a vasoconstriction standpoint, we have caffeine, which we know will contribute to that. Abdominal binders, this increases CSF pressure. We have complementary alternative medicines to help alleviate the symptoms as well. Sometimes a self-seal can happen. There's also the epidural blood patch that's available to be used, and this is just going to vary depending on where you seek treatment from. The epidural patch with fibrin glue has been shown to work a bit, though those with mast cell activation syndrome have shown to be a bit more reactive to the glue. And then as a last resort, surgery. And some patients will require one or more neurosurgical procedures to help fix this. But you want to exhaust these conservative approaches and treatments as best as possible, not only so that you can hopefully feel better, but that if you do end up needing surgery, you're that much further along.
Okay, so talking CSF prognosis, most patients do very well with treatment. Some patients suffer with residual symptoms of varying severity for years or even decades. Now, that can be from a host of reasons, but mainly think about the thickness or the location of the tear itself, or even a misdiagnosis perhaps, or mismanagement. There's so many things that go into this. We also need to look at the comorbidities and the simple duration of the symptoms. Has it been going on for decades? Has it been missed? Are there other underlying circumstances that pair along with it? Comorbidities, are we dealing with somebody with severe dysregulation of the autonomic nervous system? All those things come into play. And then there is some fascinating research around dementia secondary to repeated brain injury. Some of it deals into CSF leaks and spontaneous recovery from dementia in rare cases with repair of a CSF leak. But there's just so much to learn about the brain. Some really neat research being done right now.
Dysautonomia we had mentioned in being associated with or mistaken for CCI. So again, it can go hand in hand with CCI, or it can be another thing that you're dealing with separately as well that can mask the symptoms of CCI. Because as you can see, difficulty staying upright, dizziness, vertigo, fainting, irregular heart rate, difficulty with blood pressure regulation, GI problems, visual impairments, weakness, difficulty breathing, anxiety, fatigue, exercise intolerance, migraines, muscle tremors, impaired sleep patterns, frequent urination, difficulty with temperature regulation, memory and concentration problems, changes in appetite, overreaction to light or noise. So there's a lot of different symptoms that can come about dysautonomia, as also with CCI as well. So again, just something that it's always something that you want to make sure that you're working on to help control if you do have CCI as well and you're having dysautonomia type symptoms. Make sure that you're taking care of that as well. Low intracranial pressure. This can actually be from a CSF leak. Symptoms are nausea, vomiting, neck pain, dizziness, diplopia, which is double vision, altered hearing, increased pain with straining, laughing, coughing, sneezing, and sometimes has a history of having a lumbar puncture in the past or trauma to the spine area. Low pressure is reported on lumbar punctures. Contrast MRI will show what we call a venous engorgement in the pituitary glands, the veins, and the meninges. High intracranial pressure can also have a pseudotumor cerebri. You get obstructed venous flow from the brain, coming out of the brain, and this increases CSF pressure in the brain. The etiology can be from obesity, oral contraceptives, pregnancy, menstrual irregularities, Addison's disease, iron deficiency, anemia, polycythemia vera. Headache can increase while lying down. The treatment that they use for this is weight loss, serial lumbar puncture, so going in according to a schedule that you needed to have lumbar punctures to help relieve some of the pressure. And then shunts to divert the fluid can be put in if needed as well. Medications might also be used that are listed there, but again, we're not recommending medications on this. We just want to give you an idea of some other things that might be going on outside of just CCI that might have similar symptoms. A few scarier ones to talk about, but things that still have been reported to happen as well that do sometimes share some symptoms and might be worth looking into if any of these seem to match what's going on. Carotid dissection is a tear in the wall of the carotid artery. Symptoms of this are a temporal headache, so that headache that's behind and around the eyes, eye pain, miosis, which is constriction of the pupils, Horner syndrome, one-sided vision loss, and you can diagnose this on a CTA or MRA. And the treatment for this is anticoagulation therapy, so medication. But this can also happen along with vertebral artery dissection. You can have a tear in the wall of the vertebral artery as well. This usually occurs after blunt trauma or even a manipulation. And I have had a coworker in the past and also a client as well that had this happen to them after a manipulation, and not all manipulations are bad. It just depends on your anatomy and what's going on near that vertebral artery. So it can happen. The symptoms are hoarseness, contralateral loss of pain and temperature sensation in the trunk and limbs. So this is the opposite side of where the issue is. Ipsilateral loss of taste. So that's the same side loss of taste on the problematic side. Hiccups, vertigo. You can have nausea and vomiting, same side face pain and numbness. And the treatment again is medication through anticoagulation or antiplatelet therapy. And then, as not so dangerous to you, cervicogenic headaches, but they can be extremely painful. With this, we usually see a reduced range of motion in the neck. Pain is usually on one side of the face or head. It can be on both if you're having issues on both sides of the neck, but it's usually on one side more than the other. Pain around the eyes, pain in the neck, shoulder, or arm on potentially one side. Head pain that's triggered by certain neck movements or positions as well. And treatment for that is physical therapy, postural adjustments, and ergonomic evaluation potentially if it's from posture at work or certain seated postures. Occipital neuralgia is inflammation or irritation of the occipital nerves. The symptoms of this is usually pain in the upper neck, the occiput or back of the head, behind the eyes. The pain can be sharp, shooting, it can last seconds, or it can be continuous for you. You can be photo and sound sensitive. And the diagnosis and treatment is similar, and they use basically your history and try nerve blocks in that area to see if they can calm down the symptoms for you at that nerve where it tends to be irritated that's causing all the referred pain. The patent foramen ovale is actually a heart condition, and with this you have a hole between the right and left atria of the heart. With the symptoms, there's usually no symptoms, and it's not very common, but this can show up in people without symptoms and not cause a problem, but it can also cause migraine-like headaches. And you can be diagnosed through a transesophageal echocardiogram, so just a different way to test and take a picture. And then treatment is usually medication or closure if it's severe enough, but it usually doesn't necessarily come to that point. TMJ dysfunction, so that's that temporomandibular joint. This refers pain to the subocciput, which is again under the back of the skull. The temple, at the eye itself. You can have spasms in the levator scapula muscle, which is the muscle that kind of drops from the back of the head all the way down towards the shoulder blade. It can be made worse if you're wearing braces, if you're chewing a lot, talking a lot, and it can cause sleep apnea as well. So this is one of those things that, again, can, even occipital neuralgia, TMJ dysfunction, the patent foramen ovale, you can have all of those and have CCI. So that's why it's important that if you think you might be dealing with something like this, it's not just something to rule out CCI, but it's something that if it comes back that you do have CCI, make sure that you don't have these other things going on as well that you need to take care of, whether it's before or after they figure out your treatment plan. TMJ dysfunction, you want to find a physical therapist that is a specialist in TMJ work, and then also a doctor that specializes in the temporomandibular joint as well. And the mast cell activation disorder, this one can also mask symptoms that are very close to CCI. Again, you can have both of these at the same time, but headaches, brain fog, dysphagia, which is difficulty swallowing, all of those things can also happen with CCI, and it can also make your CCI symptoms worse as well if you have this chronic systemic inflammation. So again, make sure that you are treating everything that you need to, even if you haven't potentially ruled out CCI with one of these other issues, make sure that you don't have these other issues going on as well, so that you can make sure that you get the best treatment plan once you figure out what that's going to be.
So you feel like you are physically carrying your head around. Let's talk about CCI, some non-surgical treatment approaches. From a physical therapy standpoint, which is where we're originally coming from, right? We have isometric exercises, so getting the muscle to engage without requiring movement or a change in length of the muscle fibers. Some postural exercises, trying to build up a stronger, more aware base for the head to be supported and find support. We have proprioceptive exercises. Remember, that's that body awareness, spatial awareness is listed down below as well. Vestibular exercises, that vestibular system being a key component of coordination and feeling like we are in our body. Oculomotor training, which you can get pretty neat with just a couple devices we'll speak of in a moment. And then optical kinetic stimulation. Outside of physical therapy, we have regenerative therapy, and then trying to manage dysautonomia, dysautonomic symptoms, or mast cell activation syndrome symptoms as well. Now, as we dive into what to do, we're talking about isometric exercises here first. Remember that this is not diagnostic or prescriptive. Please, please, please talk to a physical therapist if you are unsure of how many or how intense to do these exercises. What should you do? Take, for example, as Dr. Patty typed out, that we can modify if you can't use your hand. Perhaps it bothers you to have your shoulders up in that much flexion. Please talk to somebody to help you modify this exercise, as we definitely want gentle and low repetition count to start and not pushing into pain at all. So by far one of my favorite topics to discuss, we have postural exercises here. And up at the top right, you see a basic scapular setting, scapular retraction. The individual in this picture is simply pretending that there's an orange between the shoulder blades and pinching them, squeezing them back together. Once again, if you're unsure how many reps, this is not prescriptive. Don't do just arbitrarily 10 by 3 second holds or what have you. Go and get some help. but a basic scapular squeeze there. We have postural awareness throughout the day. Now, on the bottom left here, this person in the skirt with the red top, it's a bit unfair because you see a shoe change in that middle picture. So from a slouched collapsed position on the left, you see a shoe change that pushes the person up into plantar flexion. This shifts the places that the load sits throughout the day as the person's walking around. The tush isn't able to work as much. We get some excessive lordosis in the lumbar spine. This pushes the chest out a little bit, and then the head has to compensate. So all the way on the right, we see the ditching of the 4-inch heel. The heels are now touching the ground. We see good power that's able to come from the glutes now, and then shoulders are in a nice set position, which is important now. Even though we have that shoulder blade squeeze, that person on the right with the green check mark above their head, they're not going into shoulder retraction throughout the day. That person is fairly relaxed there. An easy way to think about posture is like there's a spindle through your spine that you're trying to make as long as possible, or like a puppet on a puppet string being pulled. If you place the head in a good position, the body will follow suit. And then lastly on this slide we have postural strapping. So a couple braces on the right, they can be found anywhere these days, right? But some postural braces just to cue you. They're not really going to be strong enough to hold you. It's tough to overcome the powerful shoulders, especially if somebody is restricted up in like pec minor, right up in the front of the shoulder. But they give you just enough to build that awareness throughout the day. So strapping just for a little bit of, tough to call it support, but a bit of a reminder to make things feel snug.
Just like other parts of the body, you can actually do proprioceptive exercises for the head and neck as well. This is sometimes it's something that's left off of some regular physical therapy protocols because we're very concerned about the localized orthopedics and not necessarily the proprioception of a neck. But before or after surgery, whether it's non-surgical, it's something to look into to help reduce the symptoms that you're having. So proprioceptive exercises is controlling movement and understanding movement of the head. And you can do this through visual stimulation, as you see on the picture on the left. She actually has a little laser beam and she's following a maze. They're actually kind of fun exercises to do. And on the right, this is more of our standard proprioception, what we think of our proprioceptive exercises, where we add something that's not a stable environment and we add the exercises on top of it. So she's doing exercises against a ball that has a little bit of a give to it, and you can do those isometric exercises using this ball. I mean, you can put that ball up against the wall and you can make mini alphabets. Again, I am not trying to give anybody an exercise plan, but there are things that outside of standard physical therapy protocols that can be added that might give you a little bit extra edge up. So if you haven't tried these things, it's definitely something to talk about with your physical therapist to see if you can add them in or find a specialist that works on it as well. So with those proprioceptive exercises, the visual retraining, the vestibular therapist might be able to help you with that as well, along with a couple other therapists like traumatic brain injury and things like that that work on the control of the head and neck. But vestibular exercises can be done with a vestibular specialist in physical therapy that works on the inner ear coordination. So they work on 3 different things: habituation, gaze stabilization, and balance training. So it combines everything: that proprioception, body awareness, our head movement, and becoming adjusted to our head movements without becoming dizzy or feel off balance. So this is somebody to potentially look into. They are specifically trained. Not every physical therapist does vestibular exercises, but you can search in your area and find they're usually credentialed to do so through courses.
So for oculomotor training, here's where you definitely want to find a specialist, whether it's vestibular or TBI. You want somebody with some pretty extensive training, a lot of continuing education hours in this field, because it becomes a bit specific. And though you may find a therapist that knows how to use a handful of things, having somebody with both The experience, the extensive background in the training, and the hours treating people will take you a long way. A few things you might find in oculomotor training: we can have some visual processing and high coordination drills, binocular vision, visual imagery therapy, visual motor integration, and visual vestibular integration. It's great to be represented here by the picture of the kiddos on the playground. That spatial awareness is huge. So talking about spatial awareness, whether it's through occupational therapy, mental exercises, spatial awareness exercises, movement, games, exercises, location and placement drills, but being able to figure out where things are at in place to work on that precision can really take you a long way.
Looking at the whole spine is really important, just for overall, just initially trying to figure out what's going on, and then to work with somebody potentially during treatment, after surgery, before surgery. It's important to look at, because it's things that we potentially forget, because we have patients that are in the clinic and we see what we see and we don't necessarily think outside of the clinic as to what's going on. But sometimes issues at the lumbar spine can be closely related to the cervical spine, and you can see, as we talk about, those work-related postures, or even just during the day, depending on how you're sitting. If you look at the picture on the right, you can see just leaning back when he dumps that lumbar spine there, you can see the movement forward at his head. He has this forward head. So if you perform this beautiful craniocervical stability surgery and everything is perfect, and you send the person back to work and they're in that position again, straining against everything that you just stabilized, it can cause problems. So it's really important, like I said, before surgery, after surgery, is something to try for a treatment to calm things down. Because what is it, if you've had instability your whole life, or this hypermobility that's gotten worse, what is it that flared it up recently? Was there a change in your job position, desk, whatever it might be? It's something to look into to make sure that, again, no matter surgery or no surgery, if you have anything done, this is looked at in your treatment plan, because you don't want to walk out of whatever treatment plan feeling amazing and then go back to work and all of your symptoms flare up again. Another spot to look is the thoracic spine, so that mid-back around our rib cage. And sometimes just improving mobility here can reduce pressure higher up in the cervical spine, or even lower down in the lumbar spine. But again, it's just something to look at. If you can't tolerate movement to the cervical spine or work there, which I don't necessarily recommend if you have an instability, then can you work on the thoracic spine to make the cervical spine feel a little bit better? Again, things to bring up with your therapist if you are dealing with this instability and nobody's talked about your work desk and you feel like you're the picture all the way to the right, then it's most certainly something that you should bring up and get looked at. Sometimes you can just take a picture of you at your desk, as casual as you can, as normal as you can. Don't try to have good posture, and bring that in as that side picture there for your therapist, so that they can really see how you're seated, and they might be able to give you recommendations there. And then if they can't necessarily do that, they don't feel like they're qualified to do it, or they want much more hands-on for you, you can get an ergonomic consult, and that's usually something potentially as simple as talking to your doctor and having them write a prescription for an ergonomic consult with the diagnosis on there of Ehlers-Danlos or craniocervical instability, and then you take that referral to potentially your insurance company and ask them if they have names, or you can contact a company that works with physical therapy ergonomic consults as well, outside of your regular physical therapy too.
So a couple nuggets on regenerative therapies. We have prolotherapy, which is a solution injected to stimulate healing in the area of an injured tendon or ligament, and a few different formulas for injections, whether it's PRP, a plasma-rich protein, a stem cell, or an amniotic stem cell. A lot is going on in this field of research, so I would be up to date within the past 6 to 8 months worth of research, and talk to somebody and see what they've read up on. If somebody's trying to give you an injection, ask to see the research, ask to print something out. It will at least give you that first line of defense for what you feel like, is your body that you don't want to be taken advantage of, or sold something that's not going to help you out as it's necessarily billed to do so. And then have somebody check out that article if you're not comfortable reading it. But look into these things. They're spawning hope for a lot of people. Bracing. The classic cervical collar, all the movie references, perhaps you've seen the patient walking down the street, moving all over, looking down at a phone, and then popping the cervical collar on right before entering into the office. Everybody has that one story. But when we talk about bracing to support the head, and this goes for just about everything, but especially the head, when it's so much that has to be done, is we want to brace when we need to, and then remove it when we don't need it. If you're finding yourself consistently wearing a brace, you gotta be doing something consistently to work on getting out of it. You should not just become brace ridden for the rest of your life. We need to find some type of rehabilitation program, or set up a consult with a specialist if you're working with somebody and it's not going anywhere, or it might be that first initial consult if you've been self-treating largely, for the past bit of time. But we don't want to become reliant on the brace to the point where we feel like we have to have it with us, is the point we're trying to get at.
So what about manual therapy techniques in physical therapy, or with a chiropractor, or with a massage therapist? If you have this craniocervical instability, can you do manual techniques? And this is my personal opinion. Everybody has their own out there that's in the field of physical therapy or whoever they work with. So it's however you feel comfortable and that you're responding to your treatment that you're getting done. I would most certainly not recommend anything that's too impactful, or any thrust manipulations higher up in the cervical spine if you're dealing with instability. But there are other things that you can do. This muscle guarding that ends up happening in the upper cervical area is usually meant as a protective measure for secondary stability. So if you're going to disrupt that, if you're going to release the muscle tension that's in that upper cervical area, you better be ready to follow it up with stabilization exercises. And what I've seen in the clinic is that the upper cervical mobilization of these muscles that are up there don't necessarily do well as a first round treatment. So what I mean by that is potentially using exercises and these postural measures and these other things first to really build a good base before you start trying to release something that's really trying to hang on for you and create some stability. It's probably the way to go. So working more stability first, and then you may be able to work on this area, but I usually personally don't. If you're unable to tolerate this manual work, you don't feel it's safe, your therapist doesn't feel it's safe, don't have it manipulated. It's something that I usually don't touch. If there's any question of upper cervical instability, then we work around it for as long as we can. Dry needling is something that they do in physical therapy that causes a quicker release in the muscle tension, and that honestly might be too rapid of a change for that unstable area if you do have true instability. Some people do well with migraine type symptoms and things like that, but if you have true instability, it's not necessarily the first go-to. Again, if you love dry needling and it's worked well for you and you have craniocervical instability, then that's your choice, but you need to make sure that you have stability work set up to be able to support the structures once they're released. You need some form of support so that it holds everything together if you have instability. What I usually work on is working on the surrounding areas, such as the upper trap, the upper trapezius, or the levator scapula, so further down towards the shoulders, while also working stabilization exercises higher up if the person is able to do so. So I usually work further away and then potentially end up working closer. But again, usually I don't do that. Usually it's more so stabilization exercises up higher and then manual work down lower. Again, you can go into the thoracic spine, posture evaluation, all of those things to really make an effect as well. But it's not necessarily the best thing if you have true instability to mess around with the upper cervical area with your practitioner. There's some comorbidities to manage. We know a lot of people that have hypermobile EDS end up having dysautonomia and mast cell activation syndrome, MCAS. And again, these can also be things that are mistaken for those CCI symptoms, which we talked about. But again, you can have all of these at the same time. So if you're dealing with CCI, are you managing these other issues, which could potentially help your overall symptoms out a lot? So dysautonomia, and we're not going to get into, we can talk all day about each one of these. So this is just a really, really brief overview. But with dysautonomia, you want to make sure that you're staying hydrated with quality hydration. So potentially electrolyte mixes and also water, but having that electrolyte mix might help you out a lot. Compression stockings, and I've had people even wear the core compression stockings around their midsection, which seems to help. Everybody's a little bit different, but the legs, down into the ankles does work well for some. Lying down throughout the day if you need to. Reducing your overall stress, doing meditation, deep breathing can all help calm down that autonomic system. If we're talking about mast cell issues, really identifying and reducing trigger exposure so that you're not always inflaming yourself is what you need to do. And again, reducing overall systemic inflammation is the goal of MCAS. So figuring out how that works for you and your body. It's really complicated and it's a little simple at the same time. So again, not a conversation for today, but just know that, the mast cell component is something that needs to be managed so that you can calm down your systemic inflammation, which can also reduce the overall pain that you're having with the CCI.
So there's a surgery for everything, right? And it's no different here with CCI, with the occipital-cervical fusion from C0 to C2. With some of those slides we talked about earlier and looked at the images, you can imagine how much this is going to help that person if they can get over the surgery, that is, right? And the trauma that the body has to go through, but we'll come back to that in a moment. All those stresses that are removed by having support finally, it's going to be pretty pivotal. Now, the surgery itself, remember that surgery is a trauma that the body has to endure. Even an elective surgery, something that's going to provide beneficial help down the road, even something your air quotes need, it's still traumatic for the body to undergo. So be extra kind and attentive and aware of what you're eating, of your stress level, of the autonomic nervous system before. Listen to a few of the other lectures and try and calm down systemic inflammation as best as possible before going in for any surgical procedure for that matter.
So how do we get CCI investigated? It's commonly talked about. It's, I don't have anybody that can test for it. My doctor's not doing the right tests. I don't know who to go to. Overall for CCI, and again, we're not talking about Chiari in this lecture, but CCI, imaging has to be done for it. Other pathologies need to be ruled out if the symptoms seem to overlap. And even though you come up with CCI, like we talked about before, it's really important to potentially look at some other things, because something like a CSF leak might be an easier solution to calming down the majority of your symptoms and going through a surgical fusion procedure that might lead to more issues down the road. So again, it's just important to potentially look at other pathologies if you feel like the symptoms are overlapping. You need to find a doctor that can read the tests that you have done. If you've gone out and you understand the tests that need to be done and you end up convincing your primary care or somebody to write a prescription for you, you now need to find a doctor that can actually read the tests. And this is potentially very difficult. The flexion and extension imaging can demonstrate a clearer picture for somebody not as familiar with the diagnosis. But if you really want to make sure that you have a good reading on it, Dr. Henderson and Dr. Bolognese, I believe that they both do tele-appointments as long as you can get your tests into them. Those are the two in the US, and they do have a little bit different way of looking at the measurements of how they send out for the tests, but having a specialist review them, if you're potentially talking about surgery in this area and you have EDS on top of it, it is worth it to find somebody that knows what they're doing. So this is, one of those things where if you don't have anybody in your area, it might be worth it to reach out and pay out of pocket to have somebody actually read it for you, and give you a firm yes or no on what you need to do, what's going on. It's an extremely difficult process. The majority of the people that get this investigated are frustrated, and it's been a very long road. It involves a lot of patient advocacy on your part if you're the patient or a family member helping you out to help give you some courage and support. But don't give up. If this is something that you feel like you have or you want to make sure that you don't have, then you need to get it investigated appropriately. You need to talk to the people that can actually read and understand the imaging correctly.
Okay, to summarize, we need to look at what is causing your symptoms. Is it from an acute trauma? Or is it something related to a historically poor postured desk position or position in your car if you spend a lot of time commuting? Is it something systemic, inflammatory? Is there something else that's changed, something big life event that's gone on that's put you under a lot of stress? Now, you need to think about this both before and say you're the person that opted to go the surgical route. You need to think about these things after surgery. What got you to the point where you needed to have internal fixation to hold your head in your position? Dr. Patty's talked about before with chronic poor postured positions. Are we just jamming that hardware back to the position that got you in trouble in the first place? So we never want to stop thinking about how we can make things better is what I'm trying to get at. Have we investigated these other possible diagnoses that we've mentioned in this presentation? Getting the correct tests done is very important. Second, having them read correctly. What we want to do is discuss these things with a specialist. If possible, somebody that's well versed and hopefully versed at all, right, in EDS as well if possible. Trying to alleviate your symptoms without surgery should always be a goal, so you want to exhaust that conservative checklist. And then be open-minded enough to consider surgery if you need it, but certainly not without taking the time to put in the work first. Okay, so that wraps things up. Here are a few references that Dr. Patty put together, places that we gathered information for this presentation. Again, we're Elevation Wellness on Facebook. On Instagram, we're elevation_wellness_CO. We can be reached via email at info@elevationwellness.co. Please seek help if you need it for any of these things. Do not try and do these things on your own if you're unsure of what you're doing. Reach out with questions, and we look forward to possibly working with you in the future. Thank you so much.